All right. So I have the following disclosures, as you can see up there. Why should we care about the pathogenesis of Anca-Associated Vasculitis? Well, first of all, when we talk about Anca-Associated Vasculitis, let's remember that we're talking about a variety of different syndromes, in particular GPA, granulomatosis with polyangiitis, microscopic polyangiitis, and also eosinophilic granulomatosis with polyangiitis, formerly Church-Strauss. But they're quite heterogeneous syndromes, and there's a lot of overlap between them. And as you will see, we understand that the overlap may actually be limiting our thinking, and we might want to think more about the differences. Unfortunately, these diseases remain chronically relapsing, with GPA being more so than MPA, and our drugs remain immunosuppressive, and with it, they remain toxic, and our research keeps on going to find better alternatives to manage these patients. So the etiology to this day still remains unknown, although we're trying to find the causing agents, or some that may trigger it at least. We now understand that there is a genetic predisposition, one to lose tolerance against the target antigens of ANCA, PR3, and MPO, and maybe others. There are clearly environmental triggers that kickstart the disease process. Some may be drugs, as you will hear later, but infections are probably the most common kickstarters of the disease process. And then we have learned over the last 20 years that the autoantibodies probably play a significant pathogenic role, at the very least in the development of the capillaritis disease manifestations. B cells play a significant role, and they are abnormal in their function. So are T cells. There are abnormal T cell functions that have been identified. And as the time progresses, and after we've started to target B cells and T cells with our treatments, we're now coming back to the neutrophils and recognize that particularly in the acute phase of the disease, they play a significant role. And as time goes on, in 2, 5, or 10 years from now, we may have another talk about how we can target neutrophils and their abnormal functions in the acute phase of the disease. So with that, I'd give you a very quick rundown on our current understanding of the pathogenesis before we talk about our current understanding of induction therapy, maintenance therapy, all with the goal to avoid the damage to the organ function in the patient, and at the same time, as we avoid toxicity and damage to organs, we need to be wary of the drugs and their side effects. So this is a tall order to cover in 20 minutes, and I might run a minute or two over. But allow me to be simplistic and not reference every single paper that has been published over the last 20 years, but zero in on a few landmark papers that have really shaped our thinking about the pathogenesis, and then summarize how we think about it today. So, of course, there's clinical evidence that supports the pathogenicity of ANCA as well as B cells and T cells. Most of our understanding at the molecular level comes from in vitro studies, and there are a few landmark animal models that have shaped our understanding of the pathogenesis, and to a large extent, as you will see later, are also shaped of potential new drug development and clinical trial design. One of the major papers that clearly show that we need ANCA for the development of generalized or systemic vasculitis or significant disease relapse comes from the early 90s from the Netherlands group, which showed that in the absence of ANCA, patients who are in remission after treatment have a almost non-existent chance of relapsing. Whereas those patients who have recurrence of ANCA or persistence of ANCA have a very high relapse rate. But it also needs to be mentioned that not everybody who has the presence of ANCA will inevitably relapse. So there is probably more than the ANCA alone that we need to develop relapses. Now, also, early on in that era was documented that patients who are most prone to relapse are carriers of Staph aureus in their noses, and we'll come back to how infections contribute to the pathogenesis of the disease. Another real landmark paper came out in the JCI from the group of Ron Falk and Charles Jeanette in Chapel Hill. They developed the MPO ANCA transfer model, which clearly documented that you really just need to transfer the autoantibodies against MPO to generate necrotizing lesions in the glomeruli as well as crescents in the recipient mice. And subsequent follow-on studies using this animal model have really given us great insights, to some of which we will get back to later in the talk. So how do we currently think about the pathogenesis of what is ultimately leading to the capillaritis? The concept really has not changed substantially over the last 15 or 20 years. It has been filled in, nuances have been developed, but overall the gestalt is still the same. We have the players. You'll see here the neutrophil. Well, this one is not doing a whole lot, so I'll use the mouse. Hopefully that shows. We have the neutrophils, the monocytes, the T cells, and the B cells, and down here we have the endothelial cells of the capillaries and small vessels, which ultimately get destroyed, leading to most of the disease manifestations we see shared between microscopic polyangiitis and glomerulonephritis, and to some extent in eosinophilic granulomatosis with polyangiitis. In the context of an infection, the neutrophils and monocytes are primed, and under normal circumstances, they express the target antigens, particularly PR3, but also elastase, on the surface of the neutrophils, and they probably use these enzymes to degrade matrix proteins as they are marching through the endothelial cell layer into the tissue, where they are drawn by chemokines to the site of their normal function to get rid of infectious organisms. Now, in the context of autoimmunity, and to some extent maybe driven also by the presence of superantigens, such as in the case of Staph aureus infection, we have an abnormal crosstalk between T cells and B cells that ultimately leads to the production of ANCA. And then once we have ANCA, the ANCAs lead to the expression of endothelial cell adhesion molecules, and they fully activate the primed neutrophils, with the result of, through interactions with the Fc receptors as well as with the target antigen expressed on the surface directly, to fully activate the neutrophils, which then degranulate and release oxygen radicals, which in turn damage the endothelial cells. As a result of this activation, we also see direct endothelial cell damage through the elastase and PR3 that can be deposited, and the PR3 has also been shown to induce apoptosis of endothelial cells, and it can induce endothelial cells to produce induce endothelial cells to, as well as neutrophils, to produce IL-8, which results in a shift of the chemotactic gradient. So now you have more neutrophils attracted to the site of inflammation, yet the gradient is shifted, so these neutrophils do not know where to go, so they get stuck at the endothelial cell layer, also precipitated by the expression of endothelial cell adhesion molecules. Now, ANCA can also interact by binding directly to the PR3 and possibly MPO deposited on the endothelial cell layer, and this can lead to complement activation, and we'll get back to the complement activation a little bit later on. So we go, in summary, skip this for the sake of time, from a predisposition to lose tolerance in a patient to possibly having infections or other exposures as a driver that, in the setting of abnormal T cell and B cell response, which in part is perpetuated by the exposure to infections, lead to ANCA production and ultimately to small vessel vasculitis. And in the case of GPA in PR3 ANCA, there may be a significant development of ANCA production through abnormal crosstalk between T cells and B cells in the tissue of the respiratory tract, which for the sake of time I'm not dwelling on at the moment further. So let's shift to treatment advances and therapies. How can we approach patients knowing what I just told you about the concept of pathogenesis? Well, we can try to remove ANCA. And in this context, it behooves us to revisit the current status of plasma exchange, which is the only short-term, immediate modality that allows us to remove these autoantibodies in an immediate intervention, in contrast to indirectly reducing the ANCA production by targeting the ANCA-producing cells, which brings us to targeting B cells. Targeting B cells probably has shaped the change of how we treat patients the most over the course of the last 5 to 10 years. We'll briefly talk about how we currently target T cells, because there is not too many agents that are currently being investigated to interfere with T cell co-stimulation and thereby T cell activity and their crosstalk to B cells, even though the T cells probably hold the key to the chronically relapsing nature of the disease. And ultimately, a couple of words on targeting neutrophils. Why would we want to do this? We know from the cyclophosphamide-induced leukopenia that it substantially increases the risk for infection in these patients. So we need to be wary of this, but the current most important aim in the acute treatment of the patients is to reduce the glucocorticoid burden that accumulates in this day and age, still leading to substantial toxicities and risks in the acute phase of the disease. So let's visit briefly plasma exchange status. The MEPEX trial, which was conducted in patients with severe renal disease, included both patients with GPA and MPA, where patients were randomized to methylprednisolone or plasma exchange in addition to standard combination of glucocorticoids and cyclophosphamide, showed that there is a short-term advantage both in survival of patients as well as being free of end-stage renal disease or not needing hemodialysis at 3 months. However, the long-term follow-up evaluation of these patients was rather disappointing when we look at what happened to these patients over many years. After a few years, we can really not differentiate the patients anymore, and there's certainly no long-lasting effect of plasma exchange on the outcome of patients with Anca-Associated Vasculitis. And we recently revisited this in our Mayo cohort of patients with Anca-Associated Vasculitis, associated alveolar hemorrhage. And when we summarize our data together with those publications that provide us with data on the resolution of the diffuse alveolar hemorrhage as well as hospital survival, we come to the sobering summary that 66% of patients who received plasma exchange had resolution of the diffuse alveolar hemorrhage and survived the hospitalization, compared to 75% of patients who had the same resolution of alveolar hemorrhage and survived the hospitalization. Now, granted, the data are not clear in terms of how severely ill these patients were, and at least in our study, there was a bias towards patients who were sicker to receive plasma exchange. But in our study, at least even after adjusting for the disease severity, there was no signal in favor of plasma exchange. So we're eagerly awaiting the outcome of the prospective randomized controlled trial, the PEXIVAS study, which currently has enrolled in the order of 650 of the target of 700 patients, which really randomized patients to receive plasma exchange or no plasma exchange in addition to standard therapy. This trial is also interesting because it had a randomization to 2 different glucocorticoid regimens, one being more the standard regimen, one being a lower glucocorticoid exposure. So this trial will hopefully give us a few definitive answers. So let's visit the targeting of T and B cells. A couple of landmark papers that stood at the beginning of the rituximab era that prompted us to try to use rituximab in patients who had maxed out their tolerability of cyclophosphamide or who had insufficient results achieved with cyclophosphamide. One got us back to Tony Fauci's publications from the NIH, who, through various experimental data, supported the notion that the effects of cyclophosphamide at doses we're giving to patients with GPA or MPA were really mediated by cyclophosphamide profound effect on B-cell function rather than on T-cell function. Shortly thereafter, a seminal paper, or actually almost 20 years thereafter, but at the beginning, shortly after rituximab had been approved for the use in lymphoma, a seminal study out of the Netherlands showed us that the frequency of activated peripheral blood B cells was higher in patients than in healthy controls, was higher in patients with active disease than in patients who had achieved remission, and it was higher in patients who had more generalized or severe disease compared to patients with localized or limited disease. Now, in the same study, it was also shown that markers of T-cell activation were abnormal in patients compared to healthy controls. Yet, there was no difference between patients with active disease and those in remission. And we'll get back to that signal. So, you're all familiar with the results of the RAVE trial, so I will only briefly touch on the key points. The primary endpoint, I will not reiterate it. Secondary endpoint was BVAS of 0 and less than 10 milligrams of prednisone. What I'd like to point out is that the numbers you get from the RAVE trial totally depend on the definitions that you apply. And when you free yourself from the 6-month time point and look at complete remission with a BVAS of 0 and no prednisone, then in the order of 70% of patients achieved it. If you are still on a little bit of prednisone, you get 80% of patients in both treatment arms who achieve this. And if you completely free yourself of the prednisone dose and just look at remission defined by BVAS-WG of 0, you get 90% in both arms. And these data are absolutely comparable to the US trial results, where different definitions of remissions are used. What is not apparent from this is that there was a substantial difference between patients who entered the trial with a new diagnosis versus patients who entered the trial with a severe disease flare. And in that, RAVE trial differs from the US studies, most of which have only enrolled newly diagnosed patients. And if we look at the patients who entered the trial with a new diagnosis, there was really no difference between rituximab and cyclophosphamide followed by azathioprine. However, the patients who entered the trial with severe disease achieved superiority for rituximab compared to cyclophosphamide. And in a post-hoc study, we also looked at patients divided by ANCA type, MPO ANCA versus PR3 ANCA, and there was no difference for the MPO Anca-Associated disease patients, but there was superiority for the patients who entered the trial with a PR3 ANCA. Of course, they are not completely independent, the relapsers and the PR3 ANCA positives, because the patients with PR3 ANCA have a much higher propensity to relapse. So once you achieve remission, whether you're followed with azathioprine after cyclophosphamide or whether you get nothing after your first 4 infusions of rituximab, over 18 months, there is no difference in the relapse rate. However, the relapse rate between MPO ANCA patients and PR3 ANCA patients differed substantially, so we probably need to treat these patients differently, particularly when we look at the design of remission maintenance trials. And rituximab B-cell targeting therapy is being used for remission maintenance. There are several models for this. You can either do it continuously or on the clock every 6 months or every 4 months, regardless of B-cell reconstitution, or you can do it like we have done over the last few years at Mayo, and some other centers have done the same, waiting for B-cell reconstitution and rise of PR3 ANCA before you retreat, which changes the intervals at which patients need retreatment. Now, the seminal study from France clearly showed that continued B-cell depletion with low-dose rituximab every 6 months is indeed superior to remission maintenance with azathioprine. A couple of words on ongoing studies targeting T cells. As I mentioned, the markers of T cell activation are abnormal even during remission and therefore probably hold the key to the chronically relapsing nature of the disease. There has been a whole host of studies that tell us which T cells are abnormal. Th17 cells have been looked at in a lot of detail. We're not going to talk about this for the sake of time. I'd just like to point out that co-stimulation has been looked at in a small pilot study by the VCRC investigators, and in this open-label study there was a positive signal for abatacept that ultimately led to the currently ongoing Abrogate trial, which is a phase 2/3 trial, randomized controlled trial comparing placebo to abatacept for chronically relapsing patients with GPA who present with a non-major, non-severe disease flare. So hopefully pretty soon we know whether this agent that is generally very well tolerated in rheumatoid arthritis can actually prevent relapses in patients with GPA. Now, I already alluded briefly to the fact that we should look differently at patients with GPA and MPA, or patients with PR3 ANCA and MPO ANCA. And actually, at the genetic level, the seminal paper from Cambridge group, together with the UVAS investigators, showed us a couple of years ago that the separation by ANCA type is actually more clear and more distinct than the separation by diagnosis. And so having an objective marker at the time of diagnosis, rather than trying to establish a diagnosis that can even shift over time, may be a good message to have and may target these patients to different treatment approaches as we go forward. A couple of words on what the MPO-ANCA transfer model has told us. One, it certainly showed the same thing as the GWAS study, namely that there is a different genetic predisposition amongst different strains of mice that is crucial for the development of the lesions. But more importantly, and leading to clinical trials of new agents, is the study of the complement system in the development of vasculitis in the MPO-ANCA transfer model. It was clearly shown that the lesions are complement dependent, the intact alternative pathway is required, and anti-C5a monoclonal antibodies could be used preferentially, therapeutically, and mice that lack the C5a receptor on neutrophils do not develop the lesions. And that led to the development of a drug, an anti-C5a receptor or anti-CD88, also nicknamed CCX168, and the initial trial results conducted by the UVAS investigators were presented at the last ANCA meeting about a year ago, showing a beneficial effect, mainly a steroid-sparing effect, and a phase 2 study in the US is still ongoing, looking mostly at toxicity of this agent. A couple of words before I close on the neutrophils. And over the last few years, the neutrophils have regained our attention, and largely to the discovery of a mechanism by which normal neutrophils fight infections. The discovery of the neutrophil extracellular traps that kill bacteria have made a big impact in a variety of diseases, including in Anca-Associated Vasculitis, where it could be shown that ANCA induces the net formation even in the absence of infection, and ANCA target antigens are detected in the nets where they are trapped or where they are displayed to help do their bacterial killing job. That remains to be seen. And the percentage of nets made by neutrophils was significantly higher in patients with small vessel vasculitis compared to neutrophils from healthy controls. And it almost got not quite close to what can be achieved with the positive control PMA. Nets were also discovered in the glomeruli. And in summary, it can be stated that ANCA can induce net formation. They already mentioned that they occur in the absence of infection. They can contain PR3 and MPO. And Staph aureus by itself, in turn, is a potent inducer of net formation, bringing us back to the role of Staph aureus in the chronically relapsing patients. So net formation, furthermore, is implicated recently in thrombosis formation, and we're all aware that patients with acute Anca-Associated Vasculitis have a substantially increased risk for thrombosis. To what extent the net formation plays a role in this context remains to be seen. But there is hope to actually intervene therapeutically against net formation, at least in the short term, either by using DNase 1 or using peptidyl arginine deaminidase 4 inhibitors, which are currently in the making. So with that, I'd like to conclude. The status of PLEX to this day remains unclear. We are soon to get an answer. Targeting B cells has completely reshaped how we treat these patients in this day and age. We're looking at the T cells again as a potential target for remission maintenance agents, and the future will tell us whether we can interfere in the acute phase of the disease by targeting the neutrophils or what they do abnormally more specifically, so that we can hopefully get by with less high-dose glucocorticoids. Thank you.